Welcome back to the second half hour of HeathCall Live. Today we're kind of focusing on pain and helping you get through a lot of pain. In the first half hour, we were talking about some advanced cell therapies, and this half hour we're going to focus on physical therapy and the role that they can play in helping you get through pain before you get to those other treatments, really. Dave Kuhn is with us. He is the co-owner of Indiana Physical Therapy. You'll find them online at indianapt.com. Thanks for coming in.
Well, thanks for having me.
You bet. It takes 7 years to become a physical therapist, 7 years of training to become a physical therapist.
Right.
What are you learning in all that schooling?
Well, you're learning how to evaluate and then develop a plan of care for people who are injured. You know, our specialty is orthopedics, but there's lots of specialties within physical therapy. There's geriatric care, there's wound care, there's lymphedema, there's vestibular training, there's even some women's health specialties. So there's lots of specialties. But so in that 7 year, you know, the 4 years of undergrad, and then the 3 years of physical therapy school, what you're learning is just the basic skills of how to evaluate and develop a plan of care. And then after you get out of school is really when I think you develop your skill as a physical therapy. What you do postdoctorate, the education you get, the on-hand experience that you get really defines how you treat people.
So you help run a big business. You've got four other partners?
I've got 2 partners.
2 partners.
Yes.
And so you guys are running 18 clinics around the state. Right. So a big business. But I was surprised, Dave, to learn you're not working on the business as much as you're working in the business. You're seeing patients every day still.
Sure, that's because that's what I'm good at. I'm not really good at running a business. And we have people who do an incredible job. John Smith is our COO and does an incredible job of organizing the company and running the company, making sure that we're doing the right things and getting paid and developing relationships with insurance carriers. But Andy Vogel, Troy Smith, and I are the owners, and we used to, run it ourselves, and what we realized is we're really good physical therapists, and we're kind of mediocre businessmen. So we hired someone to run the business so we can do what we're good at, and 2, what we really love to do. So we're all treating patients all day long.
Wow. So that's great. So you get the owner working on you in this place. Yeah. Do people know that? Do they know, hey, I'm talking to Mr. Big here?
I don't know. I'm not Mr. Big, but certainly. I think it's, at least I hope it's impressive to our therapy staff. So because we're in the trenches with them. And so, it's a therapy company run by therapists, so we do things the way that we think is good for patient care and good for development of our skills, rather than just money and volume and things like that, which I'm not saying those are bad. I mean, those are important when you own a company. Right. But we think the most important thing is, how well do we take care of patients? That's our product. We don't manufacture widgets. Our product is patient care. So the better we are at patient care, the better company we are. And so we spend a lot of time, a lot of money, and a lot of effort in developing our skill set. We have, I think we've talked about this before, at least with somebody that we sent here before, is that we have the largest collection of certified orthopedic manual therapists in the world under one company umbrella. And it's a really prestigious postdoctorate or postgraduate certification. And it means that we are really good at doing manual therapy.
And let's talk about that. So in preparation for talking with you, I watched a bunch of YouTube videos, which is how the world learns these days.
That's how we learn. Isn't it how everyone does it?
I don't believe that at all. But I could see these guys, and I assume you do the same thing. So we're talking about actually hands-on moving, manipulating joints and moving your body around to relieve a number of conditions. Yes. And it looked to me like you guys are touching me and feeling my joint and getting in your mind a visual representation of what is happening inside that joint. Am I correct?
Absolutely. Yeah. And so what all those postgraduate courses and time spent is doing is developing our hands to feel what normal is. We do a lot of classes and we work on each other a lot, so we feel what normal is. So that when someone comes in and we find abnormal, now we know what to do. We know how many degrees or how far this joint should move. And when it doesn't move that way, especially in a unilateral direction, so if it moves fine one way and not the other, then we know that we need to do some joint mobilization.
And so what is joint mobilization?
Joint mobilization is just taking a a joint and passively taking it to its end range and either thrusting it or holding it or doing repeated gentle motions, kind of feeling what that patient needs. If a patient comes in really painful, we're certainly not going to do a thrust manipulation on them, but we know that they need mobilization. So we'll calm down some of the irritation, and then we'll take that joint to its end range and try to pick up more motion. We do that mostly through our hands, and then once we get that, and I think you and I talked on the phone the other day, then the important part is showing them exercises to help keep that improvement. If they're just coming in and I'm mobilizing their joint, and then I don't see them again for 3 or 4 days, and I mobilize that joint, they're going to stiffen back up. So to send them home with something that's going to help improve the range of motion, the carryover is the home exercises that we develop.
Gotcha. So what you're doing is different than chiropractic because they may be mobilizing joints, but then you're taking it to a whole different degree.
Well, so I'm not a chiropractor, and right. I've never studied chiropractic, so I don't pretend to know exactly what they do. But I think the general concept that at least what I get from patients who've seen chiropractors and us say that they'll get manipulated or mobilized, and then they'll have some pain relieving modalities. But there's not a lot of emphasis usually with most chiropractors and with the therapeutic exercise follow-up. And that's where I think maybe we differ. Again, I don't pretend to know what chiropractors do, but I do know what we do.
So talk to me about some of the conditions that this mobilization is going to treat. I have read about one called frozen shoulder.
Oh, yeah.
And it's very common. It is. I'm fortunate never to have suffered that, but describe it for me and then how you fix it.
Frozen shoulder, and there's lots of reasons why a shoulder will freeze up. A lot of diabetics will have a minor trauma, and then that capsule that surrounds the joint stops producing synovial fluid, and then the joint gets real kind of gummy and sticky, and then you start to lose range of motion. And then what happens is, if at first you were able to raise your hand above your head and that hurts, so you stop raising your hand above your head, maybe to shoulder level, and then that hurts, and then you can't even get to shoulder. So it's a progressive restriction in range of motion process. So they'll come to us with a frozen shoulder, and it can be post-trauma. There's lots of reasons. Post-surgical, people just don't move it because they're painful and afraid, and then the capsule tightens up. So they'll come to us, and we'll evaluate them, and we will start mobilizing the glenohumeral joint. So there's the ball and socket of the shoulder. We'll get that, and we'll mobilize that either gently or aggressively, depending on what the comorbidities and what the physician and the therapy staff agrees is safe to do. And then we will mobilize that, we'll stretch it, and it's pretty painful. And that's one of the conditions that is uncomfortable to do while we're doing it. Most of the mobilizations that we do shouldn't be uncomfortable. They may feel tight, but not uncomfortable. And then after we evaluate, or after we treat the joint mobility restrictions manually, then we'll give them exercises, give them some pulleys to maintain that range of motion that we picked up during the session. Have them use a stick or a golf club to help push that shoulder through the end range of motion.
I know some folks older than me who are just accepting the fact that I really can't raise my arm as much as I used to, and they think it's a rotator cuff tear. They just are making assumptions and just putting up with things that maybe you could resolve. Do you see that often? All the time.
And for whatever reason, people think, well, I have a rotator cuff tear, I need surgery. Either I need surgery or I'm just going to live with it. They choose those two, I think, fairly poor options because there's lots and lots of people walking around with rotator cuff tears who are operating at a relatively normal function level. So if they have restriction in range of motion, we encourage them to come in. We evaluate them. A lot of times, it's just a matter of mobilizing that joint a little bit, getting some range of motion back, and then strengthening the muscles to help keep that range of motion. Getting the range of motion is one thing. We have lots of people who I can lift their hand up over their head, but then when I ask them to raise their hand, they can't get it to shoulder level. Well, that doesn't mean that the joint's restricted. That means that their muscles are not strong enough to lift the hand up. So then we develop exercises, in varying range of motions through scapular retraction, all these different activities that we have them do to then improve the strength so then they can actively get that range of motion back.
Dave has really quite a reputation. He's too shy to tell you about it, but you've traveled with Olympic teams and have done just a tremendous amount of work with pro athletes. And
I've been really lucky. I've been that guy at the right place at the right time and just been invited to work on some high-level athletes, and it's been very fun part of my job.
So daily stuff, though, 70% of the traffic through your 18 different clinic locations is back and spine.
Yeah, neck and back, yes.
Neck and back.
Yep.
What can you tell us about what we're doing wrong?
What we're doing wrong? Well, I don't think that we're mobile enough, and I certainly know that we're not strong enough. The majority of people who come into my clinic with neck and back pain that's not trauma-related is normally due to just poor movement mechanics, and those poor movement mechanics can usually be related to poor core stability or poor hip mobility. You look at this, the two spots of the spine that are the most affected with pain is the neck and the back. And so if you look at the joints above and below that, the thoracic spine, where our ribs are, normally very, very tight, especially in Westerners. We do a lot of sitting. So we don't get a lot of rotation. So the thoracic spine is very tight. So if we need thoracic rotation, we're going to borrow it from the joints above, which is the neck, or the joints below, which is the low back. We look at our hips. Our hips are not usually very mobile, and certainly our core is not very strong. So one of the first things we look at when we have a insidious onset low back pain or neck pain is we look at the joints, above and below.
Let me stop you. Insidious onset means there's not a trauma, there's not an injury. It just kind of comes on.
It just kind of came on. Started having back pain about 2 months ago. Started getting worse. Now I can't get out of the car. Things like that. Yeah.
Yeah. Okay.
Yeah.
So you start looking at hips and below.
Absolutely. All the time. It's funny, neck, back, and knee pain. Those are like our big three. And if you look at it, it's the joint, the ankle joint is always usually stiff. The hip joint is usually stiff and not very mobile. The joint in the middle is the knee. That's not a coincidence. The hip joint stiff, thoracic spine stiff, the joint in the middle is the low back. So, we've kind of learned, over the years that, if we can get the ankle mobile, if we can get the hip mobile, we can get the thoracic spine mobile, a lot of times the back and neck and knee pains just kind of get better. And then we teach them how to maintain that mobility and improve core stability.
How do I get that thoracic spine the attached to your ribs? That's that area attached to your ribs. So that's a cartilage joint. There's no synovial fluid. There's nothing there, right?
Right.
So it's not terribly mobile. So how do I get it moving?
The two motions that the thoracic spine usually loses is rotation and extension, bending backwards. Because look at how as Westerners we sit at computers, we sit in our car, we sit to eat, we sit to watch television at home. So we have this flexion moment all the time. So just improving thoracic extension, just leaning backwards, getting our shoulder blades back. Sometimes we use foam rolls, but you can use roll up a towel or a pillow and just lean back over the top of it and get some thoracic extension. If we get better thoracic extension, better thoracic rotation, and thoracic rotation, you put a golf club across your chest and just do some rotation like this just to improve that mobility. Then you're not borrowing that rotation from your lumbar spine.
Oh, I get it. That makes all the sense in the world. So tell me about the rolled up towel thing. Is it going down the center of my back or across my shoulders?
Across your shoulders so that you're leaning back over the top of it.
Okay. So I want
to you can even sit down. Sometimes if your chair, like your kitchen chair, hits you kind of right in the middle of your low back, cross your arms over your chest like I Jane Magini and just lean backwards. And that can sometimes improve that thoracic extension. Sometimes just 10 repetitions of that a couple times a day will just help to change your postural habits.
That is so smart, so that while I'm on the job, if I'm a desk worker, nobody's going to see what I'm doing if I'm just kind of leaning back and hey, this is my therapy, man.
Yeah, we have a lot of those little bitty exercises that we tell people. Sometimes I'll tell people to do this. Hey, once an hour, do this little exercise. So like for neck pain, we talk about neck pain. Yeah. Most of us have a forward head posture. Again, we're a computer-generated society anymore, so we're sitting there, and a lot of us are just staring at our computer screens all day.
So your head weighs 8 to 10 pounds when it's in its vertical placement, but as it tilts forward by those 10, 12, 15 degrees, that moment of force increases so the effective weight of your head can be as much as 60 pounds. Think about that.
Yeah, you've been listening to the show. I like that.
So anyway, continue.
Yeah, no, exactly. So talk about that head position. So as your head goes forward, now you've got this really heavy weight on a short lever arm, putting pressure on the neck. So I'll tell people 10 times every hour, put your fingers on your chin, push your head straight back, and get that head back over the top of it. We don't expect posture to change dramatically, but if it changes a little bit, that's usually enough to reduce the stress and then reduce the pain.
So if I start doing this, I have back pain now. If I start doing this, how soon am I going to see some results? Because, people are all about make this happen now, right?
Yeah. And again, some of that depends on how severe your problem is. Do you have any other issues in there, like, spurs and disc problems and narrowing of the spine? But usually we tell people, within 6 to 8 weeks, you should notice a significant difference, if not total resolution. Either that's with physical therapy, that's with us giving you some manual therapy on top of the therapeutic exercise.
I got it.
But anywhere from 4 to 8 weeks, we tell people you should notice that your pain level is markedly reduced in both intensity and frequency, and that your functional activity levels are much more tolerable.
So we've talked a little bit about joints being too tight.
Right.
Can a joint be too loose?
Yes, they can, and that's less common in our older population, but I see it an awful lot in young athletes, especially young female athletes.
Oh yeah, well, tell me about that. I mean, female runners have hip issues pretty typically.
Right. Yeah, and now the female hip hypermobility is not as big a deal. Where I see it, of course, I treat a lot of swimmers, and so I see a lot of hypermobility in shoulders. And especially in overhead athletes, tennis players, baseball pitchers, swimmers, and so that joint is banging around a little bit, especially in the overhead position, which is the most unstable position for the shoulder.
Right.
And so there, joint mobility and manual therapy doesn't play a big part as the stability. And there's where we'll teach stabilization exercises. We start with open chain exercises like band exercises, and I'm sure you've seen those before. And then we'll get them on the ground so that we can get what's called closed chain exercises, which is then we're getting not only the muscles that move, but the muscles that stabilize. And so we work on first of all, like maybe just hands and knees exercises, reaching with the hand, and then we'll put some weight in their hand or some band in their hand to help improve what we call the co-contraction of the muscles around a joint. And then we have to do it at speed because no one is going to play a sport moving their hand real slow. So especially a swimmer, they want to get their hand out of the water, propel it forward,
right,
grab some water, and pull it. And so once we get them to be comfortable with weight-bearing slow speed stuff, then we start adding faster speed, either with what we call eccentric exercises or just dynamic fast movement.
So is it just given that as I get to be 75, 80, 85 years old, I'm going to be stiff and sore? I mean, is there a way to avoid that at all?
Absolutely. But you got to start now. I mean, you can't wait till you're 75 and 80 and start a program because some of that damage is already done. So when you're in your 40s and 50s and you're starting to feel those effects of maturity, then that's when you want to get on a pretty regular routine. I mean, we talked, I think, in a previous show about the benefits of yoga and Pilates. I think those are really good exercise routines to start getting some aspects of those into your regular workout routine. But just developing a normal flexibility routine, and something you and I talked about again before is strengthening. And it's not just going down, taking a 10-pound weight and doing some bicep curls. You got to push strengthening a little bit harder than I think we used to tell people to do. You got to get real fatigue 2 or 3 days a week with some weightlifting. Push some heavy weight around to make sure that those bones and muscles are getting challenged.
And so how far does that go? So I go to the gym and lift weights a few times a week, and I'm not really trying to be a bodybuilder or anything.
No.
I just don't want to be crippled at age 85.
Right.
So do I push till I just can't push anymore, or just until I start to feel discomfort? How far do you need to go?
So if you're lifting weights 2 or 3 days a week, 2 of those days a week, I would take a weight that you can get real fatigue, like you can get 7 or 8 repetitions pretty good, and you're struggling to get maybe a 9th or a 10th. That's where you need to be. If you can get 25 repetitions, you're probably not pushing hard enough. If you can't get 5, it's way too much weight.
Okay. Dave, I just looked at the clock. We are out of time and got to run. My fault, not yours. Thank you for joining us. Sure appreciate you being here, and we will talk to you next week here on HeathCall Live.